All right, good afternoon, everyone, and thank you for joining us for the second session of our 2023 Older Adults and Opioids webinar series hosted by the Finger Lakes Geriatric Education Center. And we are a HRSA-funded geriatric workforce enhancement program at the University of Rochester. And our co-sponsor, the Western New York Rural Area Health Education Center, is also a HRSA-funded education center. My name is Laura Robinson, and I am the program coordinator for the Finger Lakes Geriatric Education Center. My co-host is Christine Chappell. She is the administrative coordinator of the Western New York Rural AHEC, and we are very glad that you could join us for our third year of hosting this series. Or is it our fourth year? It might be our fourth. So we just have one housekeeping item for you today. We are using Zoom meeting instead of Zoom webinar. So please use the chat button to type hello and introduce yourself with a name, job title, agency, location, whatever you want to add. We have people from across the country and the world joining us today. So welcome to folks from all across New York State, Oklahoma, Tennessee, and South Africa. And if I missed your state, please definitely put it in the chat for us. We're glad to have all of you here. And if your real name does not match your Zoom name, please put your real name in the chat for me, because we can only provide CME and social work credits to real people with real names. I appreciate that. All right, so let me go through some disclosure slides for you today. For today's session, you can see our learning objectives, and we are certified for 1 credit of CME and 1 credit of social work. Continuing education credits, we have no disclosures to declare. Neither the planning committee nor our presenter today have any disclosures. Following this presentation, I will email you with a link to claim your credits. However, please give us 30 days to upload the attendance. It does not take us 30 days, but we just ask for 30 days. It should be up in about a week, so you can log in. If you've never used our system, I will also send you a handy dandy instruction sheet that you can use. And there was no commercial funding received to support this activity. So now I'm going to take down my slides and invite our presenter, Cheryl Martin, to please put your slides up, and I will introduce her to all of you. So today we have Cheryl Martin, who is a registered nurse of 52 years, who has 13 years experience in surgery and medicine, and then 32 years in behavioral health. So we are thrilled to have you with us and all of your experience, Cheryl. She currently works for Coordinated Care Services Incorporated, or CCSI, as a consultant and a trainer. She has a trauma certificate from the University of Buffalo School of Social Work and is a master certified alcoholism and substance abuse counselor, or a CASAC, and she has been a member of the Motivational Interviewing Network of Trainers since 2004. So we are extremely honored and privileged to have such a dedicated and knowledgeable practitioner with us today. So I will now turn the program over to Cheryl Martin.
Thank you very much, Laura, and thank you, Christine, too, for your help, and to the rest of you that have joined us. I'm honored to be here today. I think probably something in the title of this training I match, and that's the older adult piece of it. I will be 74 this month, so perhaps I have some standing to be able to talk about older adults, as I happen to be one. So we're going to spend time looking at toxic stress, histories of trauma, opioids, and older adults. And my purpose in this is to emphasize what we can do and what we can bring. And from my perspective, and again, like I will say of anybody, we all have our own narrow perspective of the world. For me, the idea of bringing compassion and hope is what's most important. So what we're going to talk about and expand on is to understand the impact of trauma and toxic stress throughout the lifespan, how it can continue to impact us as older adults, describe and consider bringing trauma responsive principles into our daily work. So what do those principles mean? How do I do that? And focus on the way of being skills of motivational interviewing and trauma responsive care as tools that support a helpful relationship with elders we serve. And I guess it's important for me to put out there my areas from which I come with this. And that really is, I've spent a lot of years in motivational interviewing. As you heard, I've been part of MINT for since 2004, and also quite a long time in the trauma responsive, trauma informed kind of world, and figuring out how these things all fit together. I will talk a little bit here just about what we know, and this is not a lot of data and statistics. I can say that it does not surprise me, some of the things that are happening, and as you may know from my age, I was growing up in the 60s as an adolescent, so I know a little bit about my generation and what was going on at that time. So I'm just going to move this out of the way. So the number of opioid deaths among the 55 plus is growing rapidly. It's one of the groups that is growing the most rapidly. The only one a little more is the one just below that. There is an increasing proportion of adults aged greater than 65 that are using opioids, with approximately 1 million living with an opioid use disorder. And that's what we know, right? Those are the ones that we can recognize and know about. Here's the piece that I think is most important to think about. The prevalence of pain in community dwelling elderly is 25 to 50%, and for nursing home residents as high as 70%. That becomes the challenge and the dilemma for healthcare providers, is how do we address pain, help to prevent opioid use disorder, all at the same time. And the other thing that really is kind of caught up in this is the fact that one of the things we know from the Adverse Childhood Experiences study, the ACE study, is that it has that dose response. The higher the number of ACEs that people had experienced in those first few years of life, the more likely they are to have chronic pain. There is a connection between what's happened to us and our experience of pain and our ability to be with that pain as we get older. So what is it about opioid use and older adults that is really very concerning as we age? Number one is that exact thing, the pain syndromes and the comorbidity of other chronic health challenges. So I mentioned from the ACEs that there's a higher chance of having a pain syndrome if you've had early childhood trauma. There's also a high incidence of all other chronic illnesses that we have: heart disease, lung disease, autoimmune diseases. All of those are also in that same dose response for the experience people have had as children. It's something I want to talk about just for a second. We are challenged a bit in healthcare, at least over it's actually 53 years that I've been a nurse and working in healthcare. We have a good handle on acute care, the broken bones, the lacerations we have to sew up, the infections we can give an antibiotic for. The world of chronic illnesses, including physical, mental health, addiction, those ones we've struggled with. And I think the issue is, and I'll say it as I see it, is it's more uncomfortable for us. There isn't a fix. In fact, there is a necessity to stay with this for the rest of somebody's life often. And it's a journey, making head start here and then pulling back here and then going back up again. And I think it's harder for those of us in healthcare to get the satisfaction in our job when we're looking for something that can be fixed, or that's how we gain our own feeling of worth in the work we do. So that is one of the things that we can expect if there has been significant trauma in somebody's life, that there may be these various pain syndromes that have something to do with childhood trauma that hasn't really had an opportunity for healing. I see it. I see it in some of my peers. Old hurts and pains that come from 70 years before still playing out in the bodies of the folks that are now in their 70s and 80s. We also have the issue of changes in metabolism. It's slower. Our kidneys may not be excreting as well. And our stamina, even I've noticed for myself, and I'll put that out there, things I'm a kind of very independent, love to be on my own and do things and go places. But even I have the sense now sometimes of, would I be able to get myself through that if something happened? There's something real about getting older and adjusting to that and recognizing that things that we could do when we were younger, we no longer have that stamina to do. Presence of dementia and that slowing of our cognitive functioning. All of these things you can see as we talk about them. When you mix opioids with this, there's some significant concerns that we have to bring into it. Polypharmacy. In fact, I can remember going out to train somewhere down in the southern tier. It has to be 15 years ago, when I had this really significant concern. I was watching what was going on with older adults and with opioids altogether. This was before we were even talking about it, because I could see that there was something changing in our culture and in healthcare that was of concern. And polypharmacy is one of those things that we were seeing. We were trying to help older adults that may be using alcohol or something like that at the time, and seeing that they're on 8 other things that all interacting with each other. Side effects can be more problematic, especially things like constipation, urinary retention. Our gastrointestinal system doesn't work quite the way it used to. All of these things can be a problem. And then the sedation. And the sedation that increases risk for falls is a real concern with opioids. It's a concern with any substance use, even those things that are prescribed. There's a tendency for us not to notice when an older adult comes into an emergency room with a broken hip, to take note that maybe there was some reason why they fell. And it may have something to do with their medications or a couple of glasses of wine after dinner. It's, you know, it can be just any of these things that might be causing us to have this less stability, fall, break our hip, that kind of thing. Do we ask? Do we try to seek to understand what made them more vulnerable at that time? And then respiratory depression, especially with folks with chronic pulmonary disease. So people with opioid use disorder have disproportionately higher trauma and toxic childhood experiences. I'm not sure, I don't have the numbers in my head about just opioids on their own, but I do know that when they looked at the adverse childhood experiences data, that people that had 6 or more of those categories of childhood trauma, so let me quickly say them: physical, emotional, sexual abuse, physical, emotional neglect, a parent in prison, parent with mental illness, parent with a substance use disorder, divorce, and domestic violence. Those were the original 10. And if people had 6 or more of those in their early childhood years, they had a 4,700% greater chance of being an IV drug, somebody who uses IV drugs. Being thoughtful about my language. It does say that in the data, but I'm going to say it's somebody who uses IV drugs. That tells us something. And this is the important thing for us to understand, that this is part of the story that we're seeing. It is possible that the adverse childhood experiences affect reinforcing properties of opioids by changing something in our brain, our opioid system. That's possible. It is possible that childhood trauma may sensitize us to those effects. And, you know, I push back. This is data that others have written about, but pleasurable effects, yes, perhaps, but maybe from that sense of dealing with the pain that they bring from whatever has happened to them. And if true, it would be important to be aware of this when prescribing opioids, because if there is a higher risk for somebody to become dependent or to use them in a way that was going to be maybe harmful to themselves, that's important for us to know. It will also be important to be aware of the stigma and implicit biases that we might bring. There is a stigma already for being an older adult in some ways. And if we add substance use, opioids, some of these other things to it, even other chronic illnesses like diabetes. So what are these stigmas that we might encounter every day, especially as an older adult? Well, we have, often we're in retirement, so occupation may not be the issue, but there are stigmas around retirement too. Sexual orientation, perhaps. Age-related, certainly. There is a difference that even I have felt at this point, subtle, but it's there. Race-related, gender-related, class-related, and then the things that we deal with all the time, health condition related, substance use disorder, schizophrenia, diabetes. So what does the culture and or the individual believe about the person? This is so important in the work we do with people every day. One of the things I've learned is that having been the director of an inpatient rehab for substance use for about 15 years, I spent a lot of time with patients. And I know that when we have how we think about them in our own head as the providers of care will show in our body language, our facial expression, and our voice tone. If I see you in a certain way that has one of these stigmatizing connotations where I see you as less than, less worthy, less whatever, it will show and they will know. I spend a lot of time noticing what I'm thinking about other people so that I can deal with my implicit biases as best I can. What happens to people if they are the focus of stigma? And this is something we can see happen with people with substance use disorders. We can see it with people who are entering into elderhood. They recognize the message. They start to notice it happening. After a while, they start to anticipate the message because they've heard it so often that they're expecting it. It's almost that anxiety we talk about in early childhood trauma, where because it's happened a number of times, they're spending a lot of time anticipating it happening again. So they aren't really able to live in this space in a way that isn't anxiety producing. And then the third thing is, and the saddest thing about stigma, is that people internalize the message. They internalize the message and start to believe the message that's being sent to them. Secondary stigma or self-stigmatizing. Here's the hope. We can bring it. We can activate. We can counter that message of stigma to the people we serve. I did just hear earlier today in another event that I was in, concerns from somebody about some of their patients that were coming back and saying they were not feeling that they were respected and that anybody cared about them in certain, I'm not going to say where, and I'm not going to say what level of care, but they were feeling that they were not valued, They were not worthy. They were not respected. How can we counter that message of stigma? How can we counter those implicit biases that we bring? Because we all have them. So the impact of trauma and toxic stress throughout our lifetime. There's a multiple sources of trauma and toxic stress that can shape our health throughout our elder years and into our elder years. And we know that that trauma in the first 5 years of childhood can at any time in our life still impact us. And the thing to think about with that is, am I contributing to it in how I view the person in front of me? And if I'm not, how can I be with them in a way that they are not feeling the stigma, in a way that I can create some safety and trust for them? I want to talk quickly about the importance of our genetics, our epigenetics, and our childhood experiences and protective factors. I won't go into the science of epigenetics, but I will talk about it in a broad way. So everyone on this training right now, all of us, have our unique genetics. Unless you have an identical twin, there's no one else that's carrying the genetics that you have. Not only that, we have our unique epigenetics. That is, what's happened to our genes being turned off or on or off, methylated, because of some toxic stress or stress in our environment that does that. We really didn't know as well as we do now that that gets passed down from generation to generation. It certainly supports the idea of intergenerational and historical trauma, and that it sits not only in what's happening to me today, but in the epigenetics that I received from my parents, my grandparents, from as far back. Good news about epigenetics is that that can change. It isn't like our genes, it does have the ability to change. Then we have the childhood experiences of trauma that happened to us in those first 4 or 5 years of our life, and the protective factors. In fact, the research shows that if a child has one caring, loving adult in their life, that can make all the difference in how the trauma impacts them going forward as they grow up. A great story comes from Oprah Winfrey, and it's Bruce Perry. Dr. Perry has been working in the field of trauma for a long, long time, and they wrote a book together talking about Oprah's trauma as a child, and Dr. Perry talking about his experiences and giving wisdom from what he knows about trauma and about how to deal with it. And Oprah tells the story that when she went into 4th grade, so she'd be about 10 years of age, she had a teacher who embraced her right from the moment she walked in the door, helped her feel like she belonged, helped her feel worthy, helped her feel safe, helped her feel that she could trust. And I would say that she's had a fairly successful life since then. So what happens to us in those 5 years, first 5 years, is really important. Child development, folks working in child development say that by the age of 4 or 5, we've developed our worldview in many ways. So if my first 5 years were one where I had neglect, I had some maybe abuse of some kind, I didn't have that at least one caring adult in my life that could support me and help me feel safe, then my worldview is going to be, and I don't think we have a whole lot of folks on here, so maybe some folks would be willing to put something into the chat about what do you think the worldview would be if you had that beginning, those first 4 or 5 years. How are you going to view the world? And maybe I could get some help, either Laura or Christine, paying attention to what people put in there and share it with me.
Yeah, so far we've got Katrina says, I'm not safe anywhere.
Yeah.
I'm
No
not worth
safety,
loving.
not worthy, not safe. Yep.
People cannot be trusted.
It cannot trust. And those are really the, most prominent things that will happen. And can you imagine, I won't ask you to put that all in here, but can you imagine how that little person's life is going to look going into the world with that feeling? We all sit on that continuum somewhere, don't we? And so the other end of that is you're the child that is born, that is able to bond with at least one loving and caring adult, maybe more, 2, 3, 4. You're the child that has your needs met. When you cry, somebody responds. You're heard. What's your worldview going to be like? And we can put that in there.
Yeah, we had a few more answers of being
okay. Let's do it.
Alone, not able to rely on anyone. I don't know how to cope. Someone else was also going to say alone, and then unsafe, non-trustworthy, and suspicion.
Yes, yes. And I will say the next piece to that, and then we'll look at the other side of it. These are going to be little children who may be doing what some adults would call acting out. They're doing whatever they need to do to survive, which often ends up creating more toxic stress for them as they go through our system of schooling and sometimes the criminal justice system. So what's the idea about if we have the opposite of this? Where are we going to be? What is our worldview going to be?
Now the answers are coming faster. I'm safe, loved, and belong, supported, connected, seeking others to trust, love, safe. The world is violent and I need to be violent to survive. There's also that. Trust, safe, and love.
That's interesting about violence, and I'll talk about that in a second. But yes, we're going to have pretty much the opposite worldview of the person who's been in the trauma or the toxic stress. And every one of us on this screen right now is somewhere on that continuum. It isn't an all or nothing, either or. It's somewhere on that continuum from our own experience. But here's the challenge. Unique genetics, unique epigenetics, unique childhood experiences. We all come from a slightly different worldview, a narrow worldview. You'll hear me say that. From my narrow worldview, this is what I see. Can you see where the challenge comes when we're trying to be together and work together? When that person is 80 years old and has had a lot of childhood trauma and is still impacted by it, but the person that's serving them is somebody who came from the opposite and sees the world as safe and trusting, there's a disconnect. Or if it's the other way around, how do we as humans, how do we in healthcare be able to move across that divide, that difference of all the worldviews that we have in this society? So it's something to think about. And it is the thing that separates us when we don't take initiative to help it bring us together. Evidence that toxic stress alters brain development, we know that, and social processes also play a key role in the impact on us. So these are all the things that the older adults can bring, including that pain that we talked about, which can be psychological and physical, including all those chronic illnesses we talked about, which are more likely to occur when somebody's had a history of toxic stress, trauma. We know it's a dose response. I talked about that. And we know the more types of trauma, the higher frequency of it we experience, we're more likely to have these things that I've talked about. Plus the social issues, the social and relational challenges that are out there for us, which is important in our health, isn't it? When I cannot find a way to build a safe and trusting relationship with somebody who's providing care for me, It's going to be difficult, especially with a chronic illness that we talked about is so different than acute illness. It requires some sort of healthy relationship and trust and safety to be able to take care of ourselves with chronic illness. So here is my narrow viewpoint, and I will say this now. It is an aside. It has nothing to do with what I was asked to do today, but it occurs to me and it's important for me to say. From my narrow worldview, primary prevention of childhood trauma and toxic stress, and that means creation of a supportive environment for our children and their parents, is a public health priority. All the things that we spend time dealing with when we look at chronic illness, when we look at violence, when we look at difficulties in learning, all of these things could be different. They could be different if we were looking at a primary prevention rather than waiting till we see it. So how do our views and our implicit biases impact how we and others behave with the elders we support? Well, if we have a domination and a kind of power hoarding approach to life versus a partnership and inclusion, that is going to impact the relationship we can build with that elder. When I say domination and power hoarding, let me talk about it this way. If we are given by our societal hierarchy more power, and we use that to have others do what we want them to do, whatever that might be, even if it's for their good, when we use it that way, that can be a problem. Versus the partnership and inclusion where I am working with you, but I do not use my power in a way to make you do something that you may not want to do or you're not ready to do. One of the things I've noticed and I think about often, one thing that children that have experienced childhood trauma, ongoing, enduring childhood trauma, what's one thing they absolutely have none of? And just go ahead and put it in the chat. What's something they don't have any of? Anybody got any ideas?
Nothing yet. Can you repeat the question?
Yeah. When you're a little child in that age group up to 5, when you're kind of creating this worldview and where you're going, what is it you don't have? If you're
Excellent.
sitting,
If you're excellent sitting, answer from Ramona says power and self-determination.
Yes, that is it. Thank
Knowledge,
you so much.
Self-trust in trust in others.
Yes, yes. So one thing that I try never to do, even with outside of the whole, whatever role I'm in, sitting with you anywhere, is not to use a kind of dominant role with people, because I don't know who's experienced that childhood experience of trauma, who feels they have and knows they had no power to do anything about it during that time. I never want to create that feeling for them again as an adult or an older adult. Becomes more challenging when they get older. We tend to want to keep them safe and have them do certain, routines that fit into our routines. All of that is kind of taking away their own personal power, and at times could be traumatizing to them. So I try really hard to share power and not to use my power to get other people to do what I want them to do. There is something else in that, but I'll hold it for now and we'll go back to it. A not enough mindset versus an abundant worldview, that has to do with our sharing with others. If we feel in our field, whatever we're doing, that there's just not enough, then we kind of hold on to it. And if we feel like there's enough there for everybody, we're going to give it away. Some of this is systems related, stuff we can't change right now, that makes us feel that way. But it's something to be aware of. It's something to know how we look at the world and how we look at what's available to the people we serve. A defensiveness versus curiosity. And there again is if somebody is telling me something and I need to defend myself or tell them they're wrong or this is the way it is, I'm likely never going to know that person. I'm only going to know my idea. Versus taking a curious stance. I think with everybody, not just older adults, but I think with elders, it's particularly important to be curious and to listen. There are lessons to be learned, things to understand. And the fact is that they were able to survive a long time already. There must be some things that are important to know that they can share with us. And then another thing that's destructive is an only one way kind of thinking. If I think that it's my way or there's only one way and it can't be any other way, then probably we're going to find that things aren't going to go really well. A flexibility, a both and thinking. How can we make this work so that how I feel about this and how you feel about this, both of these things can be met somewhere in the middle so that your needs are being met at the same time that I'm feeling that I'm providing you the thing that's most important to you right now. So just going back on it, it is about that power piece. And I do remember, and I want to say this, a lot of people are using the word empowerment. And I have noticed that some folks, especially those who've been marginalized by our society, maybe have less power, are not always pleased with that word. If I said to you, I'm going to empower you, it may sound rather arrogant that I'm able to empower you. So I've looked at it a little bit differently. I look at it as if whoever is given the hierarchical or the inherent power because of the role you have, I have it now because I'm the one talking. If I was your nurse, if I was your doctor, if I was the teacher, whatever I am, I may have it that way, or I may have it just because of my gender, my race, a number of other things. But for whatever reason it is that I may have this power, I am the one with the power that needs to step back and give space for your power. It's very different than saying, I'm going to empower you. I got this. It's, I need to step back and I need to give the space because your potential power was always there. It was taken away. And I'm going to give that space now by stepping back. And just think about it in your work environment. I got to say this too. I have so much respect for our healthcare workers, everyone. And I've worked in healthcare a long time. So I do respect the work that I've done. I also understand that our systems have become more and more complex. And that complexity sometimes makes it difficult for us to bring the very best service that we would like to bring, sometimes even a moral injury to some, when you know what it is you really want to do and what you're able to do because of systems. And in fact, some research was done towards the second, third year of COVID, looking at burnout, and 80% of the cause of burnout was systems related. It wasn't the people we serve or the work we do with the people we serve. It was systems related. The reason I bring that up and why I want to say something about it is that I would like us not to blame ourselves for those things that we can't control. We figure out how to work in it and we do our very best and we are kind to ourselves around understanding how complex it is. Anybody got any thoughts about examples you see in your personal work and your work environment where some of these things happen? either the domination, power hoarding, or the not enough mindset, or defensiveness, or only one way, lack of flexibility.
We have a great answer by Kristen, who said that partners speaking for the patient.
Yeah. Yes. We can kind of tip that hierarchy on its end, can't we? And that power differential by being that person that's there for them. So it's something to think about when you're doing your work. And a lot of times we've had feelings that there's not enough versus this abundant worldview. And I think that's something worth thinking about too, for many reasons. And I don't have time for today, but there is enough. It's just not equitably distributed. So what do the trauma responsive principles really mean in our daily work? Well, here's what they are. This comes out of SAMHSA, and it says safety, trust, collaboration, choice, and empowerment. I'm leaving it with each of you to think about each of these things where you work. Are we bringing safety for the people we serve? This is usually more about psychological safety, emotional safety. Are we eliciting trust? Do we share power, which is what collaboration is? Do we offer choice, not rigidity and inflexibility, but choice and flexibility? And are we in the space of stepping away to give power to that person, give voice, as somebody said already, to that person? So I suggest there's a way of being to do this. There you see the partnership again, the collaboration, sharing power. You see acceptance. Can I give unconditional regard for you, no matter who you are? Doesn't mean I agree with all your behaviors, never does, or everything that you do. But it does mean that I value you because you're human, because you're there. And it is not a good feeling to think about it if I don't have unconditional positive regard. It means that I don't believe that you deserve it. And that's concerning. Empathy and compassion, being with their pain and caring to help. And then that word again, empowerment, comes up. So I want to talk about compassion quickly. There's a great book, and I think I allude to it later and actually have a slide on it. Compassionomics was written by Dr. Treziak and Dr. Mazzarelli. This came out just around the time COVID started. And they took the time, they were the head of one of the large health systems in New Jersey. And one of them, and I don't remember which one, felt that there was a need to look at compassion within the hospital, that it may have more importance than we had placed on it. And let's look at all the data and see what we can learn about it. So I say in human service, we are working to benefit the people we lead as well as the people we serve. So as leaders, we're helping our folks we lead, and as clinicians, we're helping the people we serve by creating safety and trust. I'm just going to go forward. Something important to know, part of that book, they spend time talking about empathy and compassion. And they had done functional MRIs on brains of folks to see what happens. And if I'm able to be empathic, and let's say Laura's in front of me and she's got pain of some kind, either physical or psychological, my pain center lights up like hers, lights up big time. That's what empathy is. It is the emotion. It is that lighting up of that thing that tells me something's not good and I'm there with you. What's really important to learn and to help to understand is that that isn't compassion. Compassion is an action. And when we're able to differentiate, when I'm able to say, oh, Laura is in pain, I can feel it, I recognize this, it's not my pain. So that's the differentiation. It's Laura's pain. And to be helpful to Laura, I am holding on to that difference is important. And I'm going to take this journey with her. She's going to know that I support her, I care about her, and I'm willing to go forward with her. When we do that, when we move to that action, compassion, we actually light up in our reward center. Pretty cool. And when we haven't allowed ourselves to do that in healthcare, when we've kind of put the wall up so the empathy and the compassion aren't there, we actually lose the one thing that helps us stay in our work with satisfaction, enjoying it, and that is the compassion, because it is the reward. It is in our reward center. And in fact, when we go there with someone else who's been in pain, they can see it and they move into their reward center too. Compassion lights theirs up too. So collaborating and believing our relationship with the elders can help to alleviate the elders' suffering is really important. We may not be able to change everything. So what are the mechanisms of compassion that are important to us in healthcare? What they noticed was that there were physiological effects. People were healing better. People were more likely to heal. Psychological effects, pretty profound. Enhanced self-care and activation of the person. And it's very interesting. One of the areas they looked at with compassion was looking at diabetes care. And what they noticed was if the person had a high compassion provider for their health, for their diabetes care, they had 80% better adherence to their protocol, 80%, and 41% fewer complications. In that safe and trusting relationship of where they felt cared for, where they felt valued, they actually do better. Increased quality of care overall as well. And one thing that I don't have here, there was a decrease in cost. It helped for the financial burden of health systems as well. So what do we know? Compassion can alleviate anxiety, distress, and also improve quality of life, especially when you're thinking about older adults who may not have a path of not being ill at all. You know, we get older, we start to have some arthritic pains. In fact, I got one in my left shoulder right now, and it's snowing outside. Probably that's something to do with it in my head. And so we know that we can't take everything away. But boy, if somebody walked into my room right now and said with a very sincere and caring way, Cheryl, I can see you're in discomfort. How can I support you? I would feel a lightness come to that. Just the caring. Every statement of compassion has a measurable and incremental effect. And how do you bring that to people? By listening to understand, not listening to tell or listening to defend yourself or listening to have your point of view, but listening to listen. And affirmation, recognizing their strengths and things that they do well and bring and possibilities. So it brings hope, because we know that how people believe they'll do can be a major factor in how they actually do. We know all about this, right? Placebo effect, and it's true for all of us. Our expectations will impact how we actually do. And I love this piece. This is from the book Compassionomics, where they were talking about working in palliative care and hospice, where there isn't a lot of change that's going to happen and the outcome isn't going to change dramatically. And what they said was that by bringing compassion to the work we do, for the time we're doing it, we are making the unbearable bearable for that person. This is true in substance use too, not just with elderly, but maybe the gift we bring sometimes for some people who aren't yet in a place to make any change in their life, or haven't got the resources, or have so many obstacles to overcome. The time they spend with us, we can make bearable. And then there was the HID hearing, and I've already talked about this. It helps people feel empowered to understand and manage their illness. It builds trust, and that's one of the principles of trauma-informed care. And understanding the elder you serve and their purpose, why they still get out of bed each morning. And as we know, those who have a why to live can bear with almost any how. So what's important to know? Being an elder and a person receiving services means I'm vulnerable. I'm vulnerable in more than one way now. I'm at the mercy of the people providing the service, and I'm also more vulnerable because I don't have maybe the same level of stamina that I had. And as I get older, it becomes less. Compassion protects those who are vulnerable. And failing to be compassionate, and this again is not my science, this is out of the book. Failing to be compassionate increases the risk of emotional harm, and emotional harm is usually preventable. First, do no harm. Every word matters, which is why I was cautious about my language and how I talked about use of IV drug use, right? Versus IV drug user. Language really does matter, how we view it. So, what does it take to demonstrate acceptance? That's my second piece of those things I showed you. So we talked about compassion, acceptance. It really takes intentionality, managing our own emotions, and that's our responsibility. It's even more than that. It's managing our own implicit biases and our own trauma and our own reactions to things. To have acceptance for every human being, I have to have intent first. And then to bring that compassion to enhance their experience and our experience. Like I said, the more we bring, the better our experience is too. So acceptance is a commitment. It's not something we have or we don't have. Rather, it's something we choose to practice. And that's actually a piece that Dr. Brene Brown wrote. So what is this acceptance thing? Well, one thing we know is that when a person experiences acceptance of themselves as they are by someone else, and when they're able to do that for themselves, it opens up the possibility for growth. If I feel I'm not accepted as I am, if I feel that tension all the time that people they want something different than I can bring, they're not satisfied with who I am, it's going to be very difficult for me to find what I need to be able to change. Once I feel safe in my space, that they're not going to abandon me, that they accept me as I am, now I can have some courage to do something different. So what is it? It's absolute worth. And as I said before, the opposite of that would mean that I see some people as unworthy. And I really don't want to live in a world where I view others as unworthy. Do I agree with all their behaviors? No. I mean, we're so diverse, all of us, right? And so I don't have to, though. Would I want someone else to view me as unworthy? No. Do I expect everyone to agree with me? No. So therefore, I need to leave it open to have others be different than I am. Autonomy support, I think, is important in our healthcare world. Do we believe in everybody's right to self-determination? I don't know, when I'm 85 and I'm in some institution and I'm still able to get around, but I'm being restrained because of the risk of some legal ramification, I'm not going to like that very much. I don't have my autonomy that I've always had for a lifetime. And I'm not having my wishes, which may be that I would rather take the risk of falling than to have the feeling of not being free. Is it my right? That's something that's rhetorical. I'm putting it out there. But this is what I'm saying about self-determination. We have people who engage in behaviors that can be harmful, but we have folks who engage in behaviors that could be, but the risk is small. And people are still trying to kind of contain that too. So how do we set that up, right? How do we look at that? Do we really believe? Do I have the right, when I'm given instructions about something to do with my healthcare, to decide what's right for me and what's not right for me? The reality and the truth is that when people are not in our space, they're doing as they please. And I like to look at the truth rather than pretend, because I tell somebody something that they're going to do it. Accurate empathy and what is their perspective is important for me to know. And then the affirmations we talked about before. So the degree to which helping others is autonomous rather than controlled predicts the effectiveness of the help. So when people maintain their autonomy and it's voluntary and not being mandated or controlled, it does have an impact. And this is out of University of Rochester research. Even more interesting, the degree to which helping others is autonomous versus mandated predicts the effects of helping on the well-being and self-esteem of the helper themselves. Autonomy is important. Recognizing, sometimes I smile, I'll hear a provider say, well, I let them do such and such. Do we have the power to let people or allow people to do things that aren't in our space? I don't think so. I don't think so. So that mindset maybe gets in the way with the work we do, because obviously we have some thinking in that direction. So I'm at the end, and I am open to questions, comments, and may I take this off?
Yes.
Hello,
thank you.
everybody. I can see some people. Thank you for being there, Jamie.